Okay, welcome everyone. Thank you for attending Measuring Usability in Health IT, the second in our webinar series. If you were unable to attend our first presentation, Introduction to Usability in Health IT, I will be emailing everyone after this session with on-demand viewing instructions for both presentations. Before we introduce our presenter, Gavin Liu, I'll tell you a little bit about User-centric. We are a global user experience research and design firm based in Chicago. We've applied our expertise to projects involving handhelds, websites, software, medical devices, print, packaging, and telephone services. Visit usercentric.com for more information about us. Gavin Liu will be presenting this webinar today. Gavin is Managing Director and founder of User-centric. Adjunct professor at DePaul University, Gavin's passion for measuring and improving the user experience has impacted industries ranging from healthcare to mobile devices. He is a frequent presenter at national and international conferences on usability and user-centered design. His 15 years of experience in corporate and academic environments has given him a strong foundation in user-centered design and evaluation. Throughout the presentation, if you have any questions, please send them through the GoToWebinar application, and we'll address as many as we can at the end. Gavin, would you like to begin?
Pam, thank you very much. Well, I will be talking today really about measuring usability in health IT. It's a topic of interest, especially given that it is something that can be done, and that's one of the take-home messages of this talk that we're going to give. So without further ado, let me get started. With the recent changing of the guard in Washington, EHRs have become the focus of the new administration, even in the last day or so. In a speech delivered by then President-elect Barack Obama, he stated that to improve the quality of our health care while lowering its costs, we will make the immediate investments necessary to ensure that within 5 years, all of America's medical records are computerized. He goes on to say that EHRs will not only save billions of dollars and thousands of jobs, but it will save lives by reducing the deadly but preventable medical errors that pervade our healthcare system. Here's really our challenge. The big picture need is really to make medical records electronic, thereby making information more accessible to medical practitioners, reduce costs, improve efficiency, improve diagnoses, as well as a long litany of items. But everyone on the call, I believe, is aware of this. When it comes to implementing EHRs, there's a tremendous amount of effort placed on the bits. And by bits, I mean electronic communication. This is not easy work. The effort to connect many different legacy remote systems is incredibly high. Interoperability is non-trivial and should always be on top of mind for EHR solution providers. And then one has to consider all of the programming and processes that make a system secure. All of this effort is just, it's right, and it's critically important to make sure the data are right and the security is assured. Keeping patient privacy at the top makes most sense, but the work is really about making an EHR functional. But at this stage of the game, these are really table stakes. Interoperability, security, privacy, all of these concepts should or will be table stakes of an electronic health record. They're the knife, fork, and spoons of a place setting. Just as many need different elements to make a place setting, you need elements or features to make an EHR. For example, if you're missing a knife or fork, then you really don't have a place setting. Just as not having sufficient security or data integrity, you really don't have an EHR, or at least one that's certified. Now, if we think of all the different EHR implementations, we should also recognize that having table stakes means variation can still exist. This is where design plays a role. There are many ways to build a system. Now that the table stakes have been set, the next step is to take EHR implementations and to see what is best for the clinical practitioner. This is not about placing restraints or shackles on applications. It's about making them work and improving clinical adoption. There are differences, and they will continue to exist. In fact, I believe these differences will push for more innovation. The next challenge is to go beyond table stakes and differentiate. We're better than the clinical experience. Believe me, there's much more to do and much more to be gained. None of this stifles or holds back technical advances. And now that we have the table stakes, it's really about how all the pieces come together to form the clinical user experience. So the question remains, where are we in the evolution of EHR specifically on the clinical side? Or not? Is it in terms of functional elements, or are we really ready to start to differentiate at the design level? Now note, not the system design level, but on the interface side of it. So now that we have the bits, what's the benefit? Clinicians need to enter this data. So besides the government stimulus package, what are the benefits to all of these bits? There's lots of discussion on improved quality of care, patient safety, increased efficiency. There are cost savings to be had. There's decision support at the point of care. But now we can start tracking patient activity. Thinking about all the informatics, and the list can go on and on of benefits. The opportunity really is to have this data. And I've heard lots of discussion about the benefits when we have all this data. It's data that can be aggregated throughout a patient's life, but also it's data that can be aggregated across hospital beds, across networks. The richness of information really presents opportunities that are quite astounding, but really they assume one thing, and that is that the clinician effort is optimal. Really, if a system is unusable, aside from being a burden or a pain, what will happen to the assumed richness of the data if it's really hard to use, if it's not usable? So really, I'm advocating a focus away from bits and a shift to a focus on the clinical experience, putting usability into the design process, having usability measures to baseline and improve upon. And these are some of the discussion topics that we will discuss. I know along the webinar there are topics on design, but really let's start talking about the usability measures and how we can baseline. But first we're going to do a poll. Where are we in the evolution of EHRs? Are we doing well, ready for launch? Are we at the next level and we're starting to innovate, or are we just getting started? Give it a second. So,
Yep.
Okay. Let's look at the results. Just getting started. Okay. So despite the goal of implementing EHR, from the 2008 Congressional Budget Office, we're looking at only about 12% of physicians, 11% of hospitals currently use EHRs. I know those numbers will rise, but the real issue is adoption and, in many ways, not necessarily the term meaningful use, but are we going to get the richness of data that will start to provide all the benefits of having a completely electronic system? It's not going to be easy. It's going to be a long road to climb, and we know this. There's still a lot of work to be done. And honestly, until EHRs change the way they're designed, I believe we're going to continue to have just part of a solution. We can't keep avoiding or denying the fact that implementing EHRs need to fit a clinician experience. For correct reasons, technology has driven where EHRs are today. And I believe we're beyond this. It's becoming clear that we're ignoring critical factors that pose challenges towards implementing EHRs. So what makes something usable? Let's say the lights are on right now. How do I turn off the light? Don't really need a poll on this one. I think people understand that there are some interfaces that are usable. We know what to do there. Are there universal rules or stereotypes? In this example, move the arrow to the right. And I have a poll for everyone. And that really is, if you wanted to move the arrow to the right, how would you do it? Would you turn the dial clockwise? Would you turn the dial counterclockwise? Or would you press? Okay. Take a moment for everyone to look at it. Okay, let's look at the results. Turning it counterclockwise. Again, you're not going to get a measure that has everybody picking the right answer, but apparently there are, when you look at 85%, there are universal rules. There are stereotypes to how some of these things work. Well, let's talk about some other things. We have other products to look at. I'll tell you that, look at a shower. How do I get the temperature just right? Here's another interface. It may apply the same principle, or maybe not, based on a different design. how about even more complicated interfaces? Are there universal stereotypes? The answer is yes. Human factors, usability, the concept has gone into many fields, and one of them actually is in cockpit displays. An example is in World War II. When a newly designed plane was introduced by America in World War II, it was fast, it maneuvered, it did lots of things, but one of the strange things started cropping up. Planes started to crash. And it wasn't because they were being shot down, because they're much more maneuverable than the Japanese Zero. The issue was that in the redesign of the cockpit, some dials had been moved for space reasons, technology reasons, for various engineering reasons. But the pilots, who, believe me, have a very stressful situation on their hands, they don't have time to really, truly relearn that which they have been dealing with. Or in a highly stressful situation, when they glance down to look where their fuel gauge was, and they see a different fuel gauge there, what started to happen was planes started running out of fuel much more than they ever have. And what the recognition was, then in a high stressful situation, you have users glancing at an interface, dealing with a complicated situation with a complicated interface, yet without standards, without dials that look like the dials that they had seen before, or reuse of a dial, but this time instead of fuel, it showed a different type of gauge. And by glancing down, the visual affordance, a lot of pilots assumed it was fuel, and they started to go low. So when we think about interfaces that are complicated, let's also kind of bring it home and think about a more ubiquitous interface where stereotypes, where universal standards do exist. Because the question we really have is, can interface be learned, and is learning generalized? Again, the answer is yes. Driving a car is based on a user experience. We know this experience does take time to learn, but once learned, it can be generalized. Shouldn't EHRs be like this? Consider a physician who has several places to visit in a given week. I can only imagine of all the different systems, of all the different IT organizations that a physician may encounter, going from various hospital to hospital, from outpatient clinics to ambulatory. Their key ring is probably full of a lot of key fobs. Their memory is probably full of a lot of passwords just to access all of these systems. The question I have is, once they log in, is the experience similar? Is it even possible to have a similar experience? And I would argue that the answer is yes, but it does take time, effort, and a design process that includes this experience. It's kind of a slideshow. It'll walk through it, but this same challenge that is posed to EHRs has been attempted in many other industries. Progress has been made, and here are just a few examples of past, present work by human factors, ergonomics, usability experts that have made a difference in things we do today. Numerous contributions have been made to make air travel safer. The efforts both in the cockpit safety as described, but also effectiveness and improved interaction between pilots and air traffic controllers. Nuclear power plants have a significant amount of attention placed in usability. There's a lot of human control there. In nuclear regulatory areas, the interesting thing is humans make assessments. Humans look at data, they diagnose, and they perform and execute corrective actions to maintain stability within a nuclear power plant. When you look at all the accidents that have occurred and the human error in judgment that have occurred in stressful situations, a lot of effort has been placed into making those interfaces easier to use and more intuitive. Consider driving. How would driving today be without center high-mounted rear brake lights on cars? Human factors, ergonomic professionals found use for safety features in preventing rear-end collisions, saving millions of dollars a year. That's just one of many, many hundreds of examples in how cars have evolved. Think about those with diabetes. What about all of the studies on blood glucose and monitoring systems? All of these more inpatient or areas where the patient can start to implement their own form of therapy. all of those experiences are starting to have much more involvement in human factors and usability. And a lot of that is now governed by the FDA. So you can also think about how it applies to healthcare institutions, but also think about the products around us. And there's a picture in the center of an iPhone. The products around us, those we have in our coat pockets, really, they've started to differentiate themselves with a compelling and, dare I say, intuitive user interaction. That's all done through a process. And that's a process that we've started to describe today. From a study conducted in 2005, Gans and colleagues assessed barriers to implementing EHRs. Listed here are the top 15 identified by physicians. They range from everything from lack of support to the EHR software does not meet the practice needs in terms of the ability to integrate with other systems. But what's surprising is, among the top 5 barriers identified by physicians, 2 of the top 5 are usability. They're really, if I highlight this, concern over a physician's ability to input information into an EHR, and concern about the loss of productivity during the transition to the EHR. And in some estimates, that transition is not a day, it's not a week, it's months. Those are 2 barriers that come up very high in the list of reasons why adoption is poor, but also we take a look at it and say, well, how can we make that better? How can we think about changing this important factor as we move forward? User-centric also conducted an audit, but this was just this year. And what we found is that usability is a very small part of the actual procurement process, an RFP process to purchase an EHR. After all this information we know, I mean, doctors have, it's not new that doctors have said that it's hard to input and it takes a lot of time to figure out how to use an EHR. That's not brand new. So User-centric analyzed 47 RFPs and the selection guidelines. What we found is that, from our analysis, is that 32 out of the 47 RFPs made no mention of usability at all. That's 75%, or 68%. They're not looking at usability as an important component. Of the 15 where usability was mentioned, descriptions were vague, they talked about ease of use as mentioned in the selection, demonstrations of intuitiveness and usability. Again, demonstrations. The ease of use is really focused on how do we minimize typing, simple layout. So certain rules are starting to bubble up as to what ease of use might be and general usability. So when we start to break this down, only 3% substantially addressed usability. 26% mentioned it superficially, but didn't really give some exact key terms on how to deal with it. From our content analysis, the importance attributed to usability is minuscule at best. So when we think about implementing EHRs, what is the cost? There's a clear investment of time on behalf of physicians and other practitioners to enter information, to transfer patient information into the system, to enter it. So picture a waiting room like you see here, full of patients. Poor usability directly contributes to a length of time required to enter the data, whether it's because navigating through the system is difficult or intuitive, or requires more data input by notes. What is the cost? Seeing less patients is not something that can happen. We know that's a constraint in healthcare today that's not going to change. So what can we do to make it less costly? Thinking about what happens today, you have handwritten notes that go to data entry. So you think about a chart. Usability is concerned about designing a system that meets physicians' needs, no more, no less. It's about providing an easy-to-use interface that allows for quick yet accurate data entry. That's the robustness, that's the richness that I was talking about. Yet, these are 2 different screenshots from 2 different existing EHR systems. Again, they're different. They look different. They feel different. One of the things I want to point out is that design should not be and cannot be database driven. It might not even be smart to drive from paper. I know that's kind of an interesting transition point, but the reality is, while there's some logic to make direct paper to electronic transitions, that is to say, let's make the screen look just like a paper chart. But when we talk about stifling innovation, shackling technology, we also know that the electronic medium is far different than paper. Consider an interaction with the mouse and keyboard compared to a pen. Very different interactions. Consider the screen resolution. Reading a novel online is very different than paper. And I have apologies to the Kindle because I don't have one. They may have solved this problem, but it was years in the making. The reality is your screen has nowhere near the resolution that paper does. And an easy example is how small can you read on a screen versus how small can you write using a mouse, using a pen, compared to it on paper. Okay? So what we want to do, and I will submit, that there is a lot more we can do with an interactive media that is an interface that is computer-based into a clinician practice. But we can't guess. We have to understand what the clinician practice is. So there really lies our paradox. Despite usability being a key factor in implementation, why things fail, why there's frustration with EHRs, little weight's given to usability, whether it's in the design or even in the procurement process that's used to purchase EHRs. The core reasons why they're not included could be really insufficient knowledge of what usability means. And I hope in this webinar to discuss that we can talk more about usability as something that's measured. It's a lack of understanding, possibly, of how to adequately frame usability. It also could be a lack of understanding of the tools, techniques, and metrics to ensure that usability can be measured, benchmarked, and improved. One reason to consider usability is one reason why people may not consider it as a hard measure. It's, in some ways, it's a soft construct. We've been talking about usability throughout this talk, but really, why do people care? It's really about making things easier to use. It's about making a system a time saver, not a time sink. Usability optimizes efficiency by providing intuitive navigation, clear labels, clear navigation, because the reality is you still had to learn how to use paper forms. Now we're trying to instruct and inform how to do your job on a different medium. In fact, what we want to do is closely mirror how physicians enter information or how they think of information. Usability optimizes learning by really understanding expectations and having the application match those expectations, even if they don't exist today. Because let's not constrain ourselves with what we have today. If a physician had to relearn things because, well, they're dealing with paper, well, how do they really diagnose and analyze? How do we fit that into the system today? Usability is also about accuracy. Perhaps the most important feature is error prevention and how we make usability factor into that. Okay? So usability metrics have really been an afterthought. As I described, only 3 or 6% of the analyzed RFPs address usability in a concrete way. The American College of Rheumatology says EMRs to the physician office, they looked at it and said, ease of use is one of the 5 grading criteria that we need to think about. So looking at those 3 RFPs, one of them said it's a grading criteria. Another said, from the AMA, that user experience criteria is one of the 6 categories to consider. From British Columbia's Physician IT Office, RFP stated that in product demos, we're looking for intuitiveness and usability. There's not enough detail here to understand what were the criteria, but it seems rather soft to me. It's about, well, it feels right. It seems right. So again, for the naysayers out there who say we can't measure it per se and say that no measures exist, consider this. We already described how many industries already integrate usability into the design process and use usability measurements and metrics to benchmark. Again, consider the knob. Can you measure it? Can you measure success fail? We already measured it 85% based on expectation alone, not even touching it, just showing you a pure visual 2-dimensional form. We have an 80% expectation as to how that would work. We could also collect time, how long it would take for someone to actually slide it. We have accuracy. We can measure errors. Here's a definition from an organization that's the Usability Professional Association. That's an organization that I'm a part of and other members of User-centered. Usability is an approach to product development that incorporates direct user feedback throughout the development cycle in order to reduce costs, create products and tools that meet user needs. That's from an organization that I adhere to, but they're talking about the design process, which will be in a couple weeks from now. Even the UPA hasn't described how to measure it. From the book Don't Make Me Think in 2000, Steve Krug said, well, usability really means making sure that something works well, so that a person of average ability and experience can use a thing for its intended purpose without being hopelessly frustrated. Again, very soft. But if we take a look at an ISO standard, the extent to which a product can be used is by specified users to achieve specific goals is really based on effectiveness, efficiency, and satisfaction in a specific content of use. So what we're talking about, when you think about effectiveness, it's being able to complete a task at the very root level. In efficiency, it's the amount of effort required to complete a task. And we can operationally define effort among many different dimensions. But now you're starting to see how we can start to break down usability. And then there's satisfaction, which is the degree to happiness or fulfillment while completing or performing a task. And I guess really the rather is it's the absence of pain or frustration when actually doing this. This is kind of a little interesting concept of the user experience honeycomb. One of the things that you look at here is we can operationally define whether something's valuable, whether it's credible, whether it's useful, but think about usable. And I'm actually going to highlight two areas here because when a system is usable, we want to break down findable from usable because the reality here is if something is not usable, why was it not usable? Was it not usable because you couldn't find where to go? And consider ePrescribe. I couldn't find the place where ePrescribe exists. That can make something not usable. Or is it that once I found ePrescribe, the process to actually prescribe something was unusable? And again, there are various flavors. It can be unusable, but it could be usable but frustrating. And that's where we want to start to get into the subtleties of efficiency, effectiveness, and satisfaction. There are also naysayers out there that say, you know what, usability data is just too noisy. There's just too much going on. Measurements require things to be observable. They require things to be quantifiable. But to reduce the noise, and the noise can be, well, you know, there's a lot going on in the hospital, a lot of different implementations, there's a lot of different types of physician practices, there's lots of different modules. I can list all of the differences and dice all those up to call it noisy. But that doesn't mean the measure's noisy. What it means is that we don't have sound controls, good, solid controls over the context of use. We need to simply break down, well, is it pre-implementation or is it post-implementation? Take a look at specific modules because what we're really recognizing is that not all measures are created equal. There are bad ones, there are inappropriate ones, and then there are good ones. Okay? So the types of usability metrics that we have are really broken down into 5 areas. And only a couple of these actually should be used when measuring an EHR. There are performance measures, there are issues-based measures, self-report, behavioral and psychological, and then a way to combine them to form a comparative measure. So when we look at performance measures, it's pretty easy, and we've already discussed concepts such as task success. That's pretty binary. It can be success-fail. It also can be levels of success. So you can have complete success, partial success, all the way through failure. So it can be varying degrees. So again, this is an example of where you're doing a task, you succeeded, but you struggled during that process. It can be quantified. It can be observed. We can take a look at time on task. The actual time that users take to do things. We also can set thresholds that would say, you know what, if it takes longer than 3 minutes to ePrescribe, something is wrong. So sometimes it's not about the actual time, but a threshold that we make. There are errors that we can actually count. There are many ways to measure efficiency, whether it's deviation from the, quote, optimal path. There's actually an interesting concept by Smith and Knight called lostness, which is a function of the number of different pages or screens visited by the total pages by the optimal path. So it's really different pages, the total pages, because you can go back and forth, and the optimal path. NIST actually has a combination of task success and time, where there's a ratio of task completion rate to mean time per task to create a performance measure. Again, look at the ways that we're starting to break down performance on an EHR. It can be task-based. And when we think about things such as time, some consideration should be that we only analyze the successful tasks. It really doesn't give us that much more information when users fail. So what we want to do is start to be smart. Think about the controls that we are going to apply to these measures to make them appropriate measures for use. So if it's time, we want to actually take time on successes, not failures. Okay? We want on errors. We need to have consistent definitions of what an error is. We also want to know what types of error it is, because the type of errors can be very informative in the design process, such as, is it a navigational error? Did they have problems finding it? Or was it an interpretation error? The data were presented, but because of the formatting, the placement, the look, it was interpreted wrong, the labeling. So we want to really assess those areas, as well as how do users learn? Because we know that EHRs are not necessarily designed to be walk up and use. Well, you can take those same measures across trials within a session, within breaks, or even between sessions, make it a little bit more longitudinal, to really show how that EHR performs across time. There are also issue-based measures, and that can be the number of issues found. And as you can see in this example, there's a screen on the right, and we're starting to count issues. They also can be, well, how many % of users encountered that issue as a measure. We can also apply severity ratings, whether it's high, medium, or low. So basically something that's high is something that will really prevent a task from being completed. It blocks functionality. Medium ones are those that are inconveniences that they can be potentially learned, but how we want to resolve the issue because it introduces confusion and frustration, not to mention potentially incorrect data. And a low severity is something that causes irritation, impacts an opinion of the application, but resolving it is really going to improve the experience. It's not going to prevent functionality or data from being entered. And some of the things you have to consider really is this is all based on testing with real users. They're naive to the tasks we're going to give. They may be naive to the interface. They may have had to use the interface for 6 months. What we want to do is give them tasks. We want to categorize things, have it in person, or we can automate the process. But the reality is we get this usability, issues-based measures are based on a participant experience. And the reality is it doesn't have to be hundreds of users. Lots of research suggests that 75 to 80% of the usability issues that will be encountered can be found with a sample size of 5 to 7. Okay? And we also want to understand what happens when we have an issue. How do we rate it? There are also self-report metrics. There are post-task. So what happens here is you can have post-task ratings, so you can ask afterwards on a Likert scale, hey, what'd you think? We can evaluate things on a post-session basis, so that the overall feel and the experience of using it. There are also system usability scales, or the SUS, which is actually a Likert scale that's really nice because it asks on a scale ease of use, satisfaction, expectation, efficiency, all of the measures that were defined on the ISO standard for what usability is. There's also things like the NASA TLX, which is really an estimate of workload. So when you think about NASA and you think of astronauts trying to perform tasks, what does doing and interacting with this interface mean for my workload? And while I know astronauts are out in space, I also can recognize that in the clinical practice, stress, workload is a real factor. And something like the NASA TLX as a measure of workload and how much additional workload an interface adds to your life might be relevant. We can also target specific attributes of an EHR or ask open-ended questions. Taking a look at the SAS, it actually produces a score that's a benchmark. When you took a look at a meta-analysis of 50 different studies across 50 different interfaces, what starts to happen is it's actually a pretty reliable and valid score for measuring any type of interface based on efficiency, effectiveness, and satisfaction. So again, now we're starting to compare things and find scales that work not just in a post-implementation or for one specific module, but these are actual meaningful measures that can be applied to different things, to different modules, in different hospitals across different implementations. And in the end, they still measure usability. Now, these are areas that I don't think are applicable, but just for the necessary covering. So I want to talk about behavioral and psychological. You can classify positive and negative comments, whether they're verbal, whether they're nonverbal expressions. Believe it or not, there are computerized analysis of facial expressions that can be used. I don't think it would be that hard to understand what facial expressions are when we have EHRs of 11% adoption. But the reality is there are other measures of satisfaction that can be determined without going into the level of face expression. There's eye tracking to assess where attention is. And I know that the FDA, with regard to labeling and pharmaceuticals, care a lot about where attention is placed. We can also focus on pupillary response, so the bigger your pupil gets, the harder your workload is, as well as stress, such as skin conductance and heart rate. The last type of measures are the combined ones. So you can think about things like the Harvey balls for consumer reports, or a radar chart. We're starting to track different operationally defined attributes, and we start to track them in a combined measure. So instead of just worrying about one or two dimensions, we start to have a visual representation of many different forms. These are all done in many different industries as usability scorecards. So again, metric selection is non-trivial. We need to understand when measures are good, when they're bad, and when they're inappropriate. So let's kind of take a moment and say, think about a horse race. What would be a measure that's good if each of these EHRs each of these horses was an EHR? Time can be measured. The question I have is it appropriate? Because it's possible, and I think those who play and go to racetracks would say that horses actually want to, quote, win. If that's true, then it really depends on the EHRs that happen to be in that race. So yes, time can be measured, but is it appropriate? So I want to ask everyone, what's the goal? What is the comparison to other horses? Are you going to take time and start comparing it to other races? Alternatively, I think those who understand racing know it's better to simply rank order. It's first, second, and third. Because the reality is some measures are inappropriate because there are different conditions, the different EHRs that happen to be in that race. Or if you think about the Olympics, that heat. There's also different environments. There are different tasks that the EHR may perform, different groups. So also consider, even in extending my horse race analogy, and yes, they are running in snow, there is an impact of condition. Consider wind when we think about the Olympics. Bolt can run a 100-meter dash and get a world record, but if wind conditions interfere, that record is stored in a different category. Because, yes, we can measure it, but it is appropriate. What are all the conditions that we need to control for? So there are a lot of conditions that apply to measures that we need to factor in, but it doesn't mean that usability as a measure is soft. It doesn't mean it can't be measured. It means we need to understand the context in which it was measured and control for that. So when we evaluate usability of EHRs, there are lots of different roads to take. Like many different processes, there are many different ways to evaluate something. The key is to choose a path that works. It could be efficient, it saves time, and it saves money. So when we consider this road, and when we consider and then how to evaluate, here's just one example of how to do it. The first thing we want to do is identify the key user groups. So to effectively evaluate usability, we want to identify who's going to be using it. Second, it's important to identify critical and frequent tasks. It's important to benchmark the task efficiencies. It'll give you a good baseline for a new system. How about just estimating it? What if you could just estimate it through committee or representative of key stakeholders? And I'll discuss each of these more, but the concept is let's just estimate it first, and then let's measure it. Okay? So look at number one. Again, this is just an example. The key is let's identify key user groups. Who are doing the tasks? If you're going to be measuring admin, we want to make sure that they're doing tasks that admins perform. It seems really simple, but we want to document it and lock it down. NIST actually has a requirements grid, and I've kind of modified it so I look at the different user groups. I've thrown up efficiency on the top, effectiveness, efficiency, satisfaction. And I looked at it and said, well, let's just use something basic for that. Let's look at the unassisted task completion rate, so a success, fail. Let's look for time, not machine time, but user time. And let's just have a post-task satisfaction rating for different tasks. So what we want to do is understand that this grid is what we're trying to fill out. Okay? When we identify the key tasks, we want to find those that help prioritize the EHR features that are high frequency or those that are critical. They may be low frequency, but we want to make sure that when somebody has to do it, it's measured and we can measure the performance of it. Okay? So critical to understanding what tasks, because we're not going to test all hundreds of different tasks that are out there, we want to prioritize the features. We don't want people or users or in our data to complete an uncommon task, ones that you won't likely be successful because it's designed to be there, but no one really uses it. That's where the ROI comes in. Let's focus on efficient tasks to be completed. That's the area where we can have the greatest success for implementation. Let's look for high frequency. Let's look for critical tasks. Okay. So now I've just placed simple placeholders for those tasks. To create an appointment, check eligibility for Medicare, inter-patient visits, and that really affects the admin. So if we're going to look at measures, let's benchmark them. What are the critical? We take a look at that and say, okay, let's take a look at task efficiency. Let's compare it to something. Maybe we're comparing it to the existing system, which may be paper or maybe the existing version of the EHR. What they're helping us do, what benchmarks help us do is determine the delta. How much more efficient will we be? How much more effective will we be? How much more satisfied will people be relative to what we have today? It's really critical to have this part of the puzzle fit. And also, notice some of the measures we're using. It's not always about something like clicks. It may be. Clicks may be operationally a way to determine efficiency. But when you think about it, if everything were about clicks, we might have on a single EHR module 300 sub-applications. Getting to those sub-applications would be impossible. Because if we optimize toward measures that are singular in nature, we recognize that we might be missing the bigger picture, which is why you have subjective measures on a post-task and a post-session basis. So what I want to do is we want to make sure that overall this is something that's good. Okay? So let's start establishing some goals. So we placed in here for the admin a goal. The goal is success of 100%. The goal is efficiency. It should be done in under X minutes. And a satisfaction rating of X. Okay? Well, we can actually estimate that. Various ways we can do that. So say we have 5 different EHRs. Let's assume that there are 5 more under consideration. It's not optimal to conduct a formal usability test of each system, but maybe we just want to estimate it. So one way to estimate it is simply have different users look at the system. Have them walk through the common task and take notes on it. Or have a usability professional walk through the application and identify usability issues using heuristics, research-based reviews, or deviations based on established user interface design principles. Now, the biggest drawback between having a usability professional is they're not a domain expert. But surprisingly, the differences are really mitigated because we can talk to professionals and observe how they complete tasks. The other way to do it is you can purely model it based on efficiency. You can count clicks, you can count steps. But either way, you can estimate usability before you measure it. And here's an estimation here. Taking a look at EHR A versus B, there are differences. And their differences may be meaningful. So let's take the next step. And now let's take a look at which ones are not adhering to our objective goal. And now you can start to see one EHR starting to fall out because just through an estimate, it didn't look right. Well, then we're going to test it. So how do we measure usability? So let's measure the usability of the remaining EHR candidates. Let's look at usability testing. Now again, I said that based on specific groups, it is possible to collect a lot of good data on the small sample size. Because really, the usability testing is the gold standard for evaluating usability. It's one-on-one interviews where target users, whether they're doctors, nurses, admin, they are actually completing tasks. Usability moderators are having to measure their behaviors as well as the feedback on a post-task and post-session data to identify usability issues. Okay? So the observation is really measuring usability. We can have a stopwatch. We can have a pen and paper note all the issues. We can have the user tell us what doesn't make sense. Then they complete questionnaires, whether it's a SUS scale, that's a validated scale to measure systems across different domains, or even with across simply this EHR A versus B. Now the caveat here is it's about learning. If this were an installed system, how do we control for learning at different intervals so we can start to look at improvement or benchmarking? Those are some challenges that we're always going to be faced with. But the reality is we can measure it if we understand the controls. So let's take a look at some actual data points. So again, this is an illustrative example. The purpose of this example is to define the experience, set a goal, and estimate values of how it would function, and then collect real-world data. So now all of a sudden, we're actually collecting the actual data you see there and how it adhered to the objective that the stakeholders set forth. Now, what's really interesting about this example is I know it in some ways many can conceive it as contrived. The reality is this process is similar to FDA guidance on devices in the last 10 years. So the FDA, with regard to medical devices, has established guidelines for usability and human factors engineering. They've even taken a look at the design process by which medical devices are used to improve safety, to worry about error. All of this still centers around the concept of measuring usability against a stated objective. And what's interesting is the FDA also produced numbers in terms of sample size that are relatively small because they recognize this isn't about marketing attitudes. This is about devices and how much risk can be incurred if devices are not usable. And I would propose that EHRs are similar in that they are devices. And the FDA is already providing guidance towards this. And so here in this, there are some standards that you can start to look at with regard to this. So how can we really eliminate the paradox and say, you know, usability can be measured? It's identifying the groups, it's identifying tasks, it's benchmarking, it's estimating, and ultimately it's measuring it. And that's really the purpose of the webinar today, is to talk about usability measures. And I am now open for questions.
Okay, we actually do have a question. Can you differentiate the lab-based versus in situ or clinical environment usability study? When do you need one or the other? Do you always need both? Is there a difference? And then what could a vendor expect from a lab-based usability study?
Interesting, interesting. The lab-based studies are good in many regards. The first is one of the things that we started to investigate is, okay, how are EHRs designed? And oftentimes there are key stakeholders or visionaries that start to produce a design, and we're all for that. The problem sometimes is how the design is tested. So when you consider lab testing, that's before it's been implemented. How do we introduce lab-based testing to improve design? A lot of things that I've heard are confusion over focus groups. So what happens is I bring a moderator in to show how ePrescribe works, and the moderator walks the user, and the users are in a focus group, and they may be clinicians, and they show the process. The one subtle element here, and it has nothing to do with focus groups or groupthink or egos in the room. The reality is, if I ask, how do you do something? And the very next thing that happens is the moderator says, oh, I click over here. What happens is we're leading. And it's a very different experience compared to me taking a clinician in a room and asking the very same question but leaving the mouse in their hands, not a moderator's hands. Everything seems so easy when someone pushes you in a certain direction. So lab-based testing, one-on-one, in the design process makes a lot of sense to iterate designs. And that's something that I believe we have in the 4th webinar lecture by Wendy Yee on design, user-centered design practices for EHR. So lab-based testing works there. Lab-based testing also works when you have a product and you want it to be benchmarked or validated in the procurement process. Now, what's interesting is we know that it's really hard to take something that has been built and drop it into a hospital system with all of the legacy and interoperability. And sometimes the post-implementation output is not the same as what we use, what would be optimal and ideal. That's the reality. Testing inside makes a lot of sense. And you may not even have to test in the first day. It may be 6 months later. It may be after learning has emerged, starting to test in hospitals. So I hope in the long-winded answer, pre-implementation can be tested in the design process. It can be tested as part of the procurement process. But post-implementation is where the rubber meets the road for the provider to get their ROI. And also, I would think that the vendor would find really good information there to evolve the next generation or enhance the existing EHR through post-implementation.
Okay, and then another question is, not all physicians can hire consultants working alone, perhaps, to select their new EHR. What can physicians do now to better understand usability and how to evaluate during the system selection?
So again, I still have a slide up, so it's pretty good. What are the key groups? So I think physicians can identify who those are. What are the key tasks? And if you think about what are the high-frequency tasks that this EHR is to perform and the critical ones, take a look at it. Then take a look at even the pre-implementation. Estimate how long it would take somebody to do it. Roll up your sleeves, grab the mouse, and start to interact with the interface. Estimate usability. I think that's going to take a long way into evaluating the efficiency, the effectiveness, and overall satisfaction. Put it in your hands.
Okay.
Oh, by the way, I'll add at one point, and that is the reality is even in corporations where you don't have funding to conduct a formal usability, conducting usability in this manner, what we call discount usability, is better than nothing.
Another question is, basically, will this really work? People say applications are too complex, the environments are too complex. Why not just ask people?
Ask people what? I guess I'll try to guess what that means. I think what it means, and again, I am if I'm wrong. The reality is, why don't we just ask people whether they like it? And that's reasonable. Again, that's a satisfaction measure. it's an overall measure. It's an overarching measure. It's not one that will help users or our vendors understand how they're doing on a specific task. Okay, so yes, you can ask users, but here's the key. I said ask users. Are those companies who are doing those type of surveys asking users? Are they asking CIOs? Who are they asking? Are they asking the frontline user who is trying to see 27 patients a day? That's the question that we have. And at that point, you could even shadow and start to look at other measures to collect along that line. But yeah, I'm all for that, but to recognize to make sure what the controls are and who the users are.
Another question from Bruce. If you were measuring EHRs for usability, would you have different metrics for disabled users, or would you use the same metrics for all users?
It's a really good question. It is possible to use the same measures, but I would clearly categorize or partition, shall we say, that data set. And really at that point, you're talking about probably a smaller sample size. I would go very qualitative. Understand what the experience is and start to work towards that end. But yes, it certainly can be measured. User-centric has done lots of studies on voice-only inputs and how those function, and we also measure those. It's not a huge issue, but I would, again, worry about the users, sample size, and whether I should just strictly go qualitative at that point. One question comes up: has user-centric ever benchmarked the current efficiency of EHRs for viewing and sharing cumulative diagnostic patient test results? The answer is recently user-centric had to, for conflict of interest reasons, not do those types of activities. So we've refrained from doing that. I think we will be doing that again in the coming months. Have we ever done it? We have done it for some applications, for some very specific modules in those areas, and that's kind of the key. Has there ever been a benchmark across all of the different vendors, 300 plus vendors of EHRs, across ambulatory, across all the different modules? I think the answer is no. And that would be quite an endeavor. Obviously, we'd love to do that, whether it's kind of an ARC grant or something that's fueled in different ways. The reality is, sorry, I'm talking too much. The reality is we want to benchmark it. It can be benchmarked, but it does take effort. I think there are lots of different ways. I think people can be specific about it, but we want to understand what we want to test. We have not benchmarked all of them. We have nowhere come close to it. We have actually started some programs to benchmark some, but as a benchmark comparison, if you don't have enough critical mass, there is no comparison. And that's kind of part of the dilemma.
Another question. Most of the discussions seem to be based on reviewing multiple modules for competing products. How can we apply these principles when we are building something for users, i.e. software developers? We don't have multiple things from which to compare since we are building from scratch. How do we apply these principles during design?
I'm going to defer that to, I think, the fourth webinar by Wendy E., but the summary is a user-centered design process, now that you have the table stakes, is in order. And what that allows you to do is understand on a given module that you're going to build. I know there's lots of modules, there's lots of different instances, but let's think about what a common workflow is. And I know there's arguments that different hospitals can have different workflows, but I also suspect that there are certain key clients that would be hospital providers that would provide you with their needs for a given module and their workflows. Start there. Start by understanding what their workflow is. You've got the databases. You've got the system. It's how we present that layer to the user. And then in doing so, you're going to find lots of, I won't call them shortcuts, but there are lots of ways that a clinician thinks. And what we want to do is try to capture those in the need and articulate that in a design that does a pretty good job of being what a clinician is thinking about next. And so it doesn't take very long, even in a short interview, to say, you're doing X. You're looking at this patient chart. What are you looking for? Well, given this is happening, the next thing I'm going to look for is this. So now we're starting to make the design intuitive. We're starting to make the interface not just present data, but present data in a way that's meaningful, that's prioritized, and that can help the diagnostic process that clinicians go through. And then we can continue down that path. But I think part of the answer isn't worrying about the data. It's worrying about what users are going to do with it. And that can be done through interviews and iterative testing with even a small set of users.
Another question is, the specific question is, is there a software library that can be put on the application to collect information about usability? And I think he means that there's a system that you can put electronically on to grab information about usability.
I think it's kind of the analogy of log data. So how long people spend on things, where they go, there are answers there. And there are things that you can place on there to get high sample, the actual empirical data. It's real data across all of the users. But don't use that alone because you don't know the story. You don't know why clinicians or users are doing what they're doing. Coupling that with some interviews and watching and observing how they use the system will also give a story to that data. The answer is yes. So I'm for it, but I also want to make sure we understand the why so we can affect change. Another question says, how can we apply general rules to specific users, touching on effectiveness, efficiency, and satisfaction? Well, I'm going to answer it, I think, in a couple ways. The first is that there's a really nice set of standards that originally came from cancer.net or cancer.gov. So it's a government document that has 2009 usability, user interface design principles that are evidence-based, okay? Now, you're going to have to kind of follow me here because I don't have a slide to describe this, but the concept, I think, the essence of the question is, how can we take general things and apply it to specific things, okay? One of the things that you have to think about is there are ways to design an application. At the bare root level, it's alignment. Do you know what control matches what? There are standards for that. I have seen EHRs where the medicine, a drug, is in a drop-down. And the drop-down, because you can imagine, given the name of the drug, the type of drug, the amount of dosage, is a very long set of characters. The drop-down itself truncates such that the user may only see partial amounts of data. And if you can imagine, one drug may have 7 to 10 different elements to choose from. Not having all the information at your fingertips is a problem. So there are general principles like that, and I know people can say, oh, I can't believe people do that. But I've seen more than one EHR do that in a handful of 10. Therefore, those are general principles that would apply to very specific users. I know we can get into, well, there are certain cases in which this interface will work this way. But I would urge everyone to break down the interface into its components and say, well, if there's a level to which we can evaluate and make a good design, the first level is to have user interface design guidelines that make sense. And there are thousands of them out there. They're actually free for usability.gov. It's a government-sponsored utility that it's great. It provides thousands of evidence-based guidelines. Having that is the bare minimum. Then we get into workflow. And I can understand the arguments about specific workflow not matching a guideline. I can understand that. But when we talk about interface guidelines, I think we can start with very core ones and getting those right. I hope that answered the question. Let's see. Another question that comes about the minimum screen resolution to make a usable EHR system. That really depends. It really depends on how you've constructed your design. Is it compartmentalized so that ePrescribe has all of the information that is available? Does it anticipate next steps? The reality is this. You could have a monster screen where all of the information is contained on one screen. It probably has great, if you were just counting screens, it has great efficiency, but on one measure of efficiency. I could conceive of a lot of other designs where the information is chunked in an intuitive manner. You go from this piece of evidence to another piece of evidence to another piece of evidence based on knowledge about how we diagnose patients. And so screen resolution isn't going to play as much a role there because information is chunked so that they're prioritized and it bubbles up in a way that users can see it. So unfortunately, there is no good answer to screen resolution. It really depends on how you designed it. But I can tell you that it's really hard to see small font size, especially when bold, in red with poor contrast, and decimal points that are different. So think about lab results. I have seen lab results where certain areas highlight based on scores that are out of range or anomalies, abnormal test results, but the way that they're presented actually makes it harder based on contrast, font size, boldness, color, actually make it harder to see what's wrong. And again, sometimes it's even the decimal point because you're mixing lots of different different assays and different lab results in one space, and the numbers are all across the board. How does the physician look at that information properly? Okay. I think there's a question. Will CCHIT be analyzing this in-house or outsourcing? I'm going to leave that up to CCHIT. Yeah, I'll leave that up to them. I do know that there is a push towards understanding it, but I'll tell you this. This is a hard challenge. And what we want to do is not throw the baby out with the bathwater. What we want to do is take those small steps. So I already described what are the table stakes on an EHR. Well, what are the table stakes for good usability? And that starts with good interface design principles. Let's get those right first. And then let's evolve it to workflow. There will be no silver bullet given the state of EHRs today. But taking that first slice and making a good attempt and providing information to both providers, solution providers, hospitals, ambulatory centers, all of those who purchase EHRs is the first step I think we need to take.
I know a couple people have asked questions that we haven't addressed. We'll address those privately via email. If there's any other questions, go ahead and type those. Otherwise,
no, my only final comment is I think there's some comments about how this can be done in EHRs, and I don't want to kind of mitigate or kind of diminish the effort that's been done. The reality is, whether we're talking about a Microsoft or an SAP application in an enterprise or a call center application where customer service agents are taking 100 calls a day and interacting with the system, to even like an iPhone application. All of those places, all of those systems have been tested. They are part of a user-centered design process. They're not perfect, but they're a lot better than they were years ago. And you consider banking, consider the aircraft industry. What I'm thinking, and the way I see the state of healthcare is we're taking the first steps. And the good news is we can leverage a lot of what we've learned in other areas to this. And, you know, the reality is we just need to get clinicians to get us the data, to be part of the process, not to be spoon-fed through a moderator, not to be part of the problem, but really part of the design. Because I'm hearing a lot, well, we're going to make them do it. The reality is if you make somebody do something, you're not going to get the richness of data that we think will give us all the benefits to having an EHR. And that's what we're really looking for. How do we get closer to that step? Okay, thank you very much for everyone attending.
I'll be sending an email a couple hours from now with the information on how to access the recording on demand. And by all means, if you have any questions related to this presentation, Gavin has his email up there. Otherwise, you can address any questions to HIT Usability at